Hello, and welcome to lecture number 14 in our series on drugs and human behavior. Today we're going to be talking about treating bipolar disorder. This is a particularly difficult, oftentimes, disorder to treat because oftentimes people who have bipolar disorder, while they really hate the depressive parts of it, they sometimes miss the high energy, creativity ideas that come along with the manic parts of this disorder. So we'll spend some time talking about this. There is certainly a number of resources if you're interested in learning more about bipolar disorder. I highly recommend reading Carrie Fisher's autobiography, Wishful Drinking, followed up by Shockaholic. She talks a lot about what it's like to live with bipolar disorder and how she was finally able to get some treatment. She's actually a big proponent of electroconvulsive therapy. It certainly seems to have helped her a great deal. So when we talk about bipolar disorder, first thing we have to do is discuss different classifications of bipolar disorder. We talk about bipolar 1, which includes at least one episode of mania. Bipolar 2, which includes both major depressive and hypomanic episodes, so more depression, lighter manic episodes. Cyclothymia is a less severe form of bipolar disorder. And then we have bipolar not otherwise specified, which usually only includes hypomanias. Now there's been some updating to the diagnosis of bipolar disorder from the DSM-4-TR to the DSM-5. It includes the same category, so 1, 2, cyclothymia, and not otherwise specified. Difference for mixed episode symptoms are replaced with mixed features specifier used when individuals experience the full criteria for a mania episode and 3 symptoms of depressive episode, or individuals experience full criteria for depressive episodes and 3 symptoms of mania episode. There's addition of other types of diagnoses to permit more latitude in making an appropriate diagnosis, something like substance medication-induced bipolar, bipolar and related disorder due to a medical condition, etc. So there's much more leeway and latitude in how to diagnose bipolar disorder in the current version of the DSM. So when we talk about somebody being manic, or what we sometimes call hyperthymic temperament. They tend to be very exuberant, cheerful, overly optimistic and carefree, overconfident, self-assured, boastful, to the point of being grandiose, exceedingly extroverted and people-seeking, very high energy level, full of plans, going to do all this stuff, tend to be over-involved, very uninhibited and stimulus-seeking, so they can be irritable. They oftentimes will engage in excessive high-risk activities, including high-risk sex, high-risk substance abuse, gambling, stealing. They oftentimes have inflated self-esteem, flights of ideas. They go from one thing to the next. Oftentimes very distractible, and a decreased need for sleep. And again, this is part of the reason why people who are bipolar sometimes miss this time, because they didn't need to sleep and they felt like they were getting all this stuff done. But unfortunately, it also comes with the depressive side of this, so it's something to keep in mind. So how do we distinguish the hypomania, which is a lower version of mania? Well, cheerfulness can switch from irritability to irritability when the person is crossed, as opposed to somebody who's just happy their mood is even, not so easily perturbed. People who are happy are able to settle down. They can usually get a full night's sleep. They'll usually have good judgment. Usually has no predictable relationship to the depression, and it's generally not seasonal. So you want to make sure you're distinguishing happiness from hypomania. In terms of the epidemiology of bipolar disorder, it's relatively rare, around 1% of all populations. Bipolar disorder 1 is relatively equal for males and females, whereas bipolar disorder 2 tends to be more common in females. Age of onset, most commonly first symptoms at age 15 to 19. Unfortunately, there is often a long delay, average of 8 years before you get the correct diagnosis and treatment. This disease has a high mortality rate, 25 to 50% attempt suicide, around 19% of people succeed. There's some question about a number of celebrities who might have had bipolar disorder, and that might have been the cause for their suicide or their substance use. So the risk of developing bipolar disorder is about 0.5 to 1%. Incidence of new cases per year is about 0.01% for men and 0.01 to 0.03% for women. Unipolar mania occurs in about 1% of the population of bipolar patients. And onset is almost always by the third decade, but can occur later. Again, there seems to be some variation in this. But if you look at the age of first symptoms, tends to be about 60% under the age of 19 have their first symptoms, but it's usually another 8 years before they get diagnosed and treated. You can see the largest category is in that 15 to 19 age range. If you look from 10 to 24, that is 67% of the population. So really the bulk of people are diagnosed in that 10 to 24 year, or get their first symptoms, in the 10 to 24-year-old range. And then oftentimes go untreated for a long period of time. Most patients seek treatment during their depressive episodes, so there's often a significant delay between onset of symptoms, the correct diagnosis, and treatment. These bipolar spectrum disorders generally have sort of a stable course over time, but the suicide rates are very high in bipolar disorder. And unlike in depression in the initial phases of bipolar disorder, there seem to be precipitants. That is, there's things that precipitate these events. Only 20% of patients who screen positive for bipolar disorder actually receive the diagnosis, but 31% receive diagnosis of unipolar depression, so it's much more likely it'll be diagnosed as depression instead of bipolar disorder. And unfortunately, about 49% of people with this disorder receive no diagnosis at all. Of those diagnosed correctly, most were not treated adequately. That is, they would receive something like an antidepressant without a mood stabilizer, which is an inappropriate way to treat this particular disorder. So, a little summary of these features. You can pause this and read it in more detail, but you can differentiate between unipolar and bipolar depression based on a variety of different clinical features. In terms of predictors of mortality and outcomes for bipolar disorder, predictors of mortality include poor occupational status before their sort of what we call index episode, the first time they really have that major episode. So if they haven't been working, then there is less likely that they'll do well. History of previous episodes, history of alcoholism, if their mania includes psychotic features, if they have symptoms of depression during their index manic episode, we call this mixed mania, that there's depression mixed in with mania. That's a poor predictor. And being male, also a predictor of mortality. We know that men oftentimes use firearms in suicide attempts, and so are oftentimes more likely to succeed. And then the between episode affective symptoms, if they're really having a affective disruption, excuse me, between if they're having affective symptoms between episodes, then there is poor predictor. It's a poor predictor of mortality. So what do we treat bipolar disorder with? Well, there are different classes of drugs. The classic treatment in this area is with lithium salt. Anticonvulsant mood stabilizers are often used with efficacy. Some atypical antipsychotics appear to be effective in treating bipolar disorder. There is some exploration of omega-3 fatty acids as a good treatment for bipolar disorder. But above all else, treatment is critical for this population. People with bipolar disorder can lose up to 9 years of their life. They can lose up to 14 years of effective activity, 12 years of normal health. 20 to 25% of people who are bipolar who are untreated will attempt suicide. Suicide completion rates in patients with bipolar disorder 1 may be as high as 10 to 15%. 60% have comorbid substance abuse disorder. So it's very critical to get these people into treatment. And most estimates indicate only about a third of people with bipolar disorder are being effectively treated. So the first drug we're going to spend some time talking about is lithium. This is a drug that has been used for some period of time. So we'll talk about what it is. We'll talk about the history of its use, talk about the pharmacokinetics and pharmacodynamics, talk about its side effects and toxicity, which is a huge problem, and some issues in lithium treatment. So what is lithium? Historically, this is the drug of first choice for treating bipolar disorder. It's the lightest of all alkali metals. It has no psychological effects in healthy people, so there's no potential for abuse. It seems to be effective in treating 60 to 80% of acute manic and hypomanic episodes. Unfortunately, there are significant issues with toxicity and compliance, and so oftentimes alternative treatments are necessary. Lithium chloride was first introduced as a salt substitute in the late 1940s, but its severe toxicity has limited its use for that. Research in the 1970s determined it was effective in treating mania. Many controlled studies demonstrate its efficacy in treating mania and depressive episodes in bipolar disorder. So it is an incredibly effective drug. Unfortunately, it has such significant side effects. Treatment with lithium requires close monitoring, but it really is the gold standard for treating bipolar disorder. So people who are taking this drug have to be monitored very closely to make sure that there is no damaging toxic side effects. So their lithium levels have to be controlled very closely. So here's how lithium is treated by the body. Peak blood levels are usually reached within 3 hours of oral administration, and you get complete absorption by 8 hours. Therapeutic efficacy is directly related to plasma levels. Although levels are much lower in the brain, we obviously focus on plasma levels because that's what we can measure. Lithium is not metabolized, rather it's excreted unchanged by the kidneys and a little bit through the skin via sweat, just like any other salt. Steady state for this drug is reached after about 2 weeks, and it has a very narrow therapeutic range, and this is one of the biggest problems, is that narrow therapeutic range. So it has to be verified by blood levels to make sure you're above the threshold needed for treatment but below the threshold for toxicity. So it's between 0.6 and 2.0 in the way those lab results come out. Above 2.0 is toxic. So it's a very narrow range in there. So there are no psychotropic effects in healthy patients from lithium. Seems to be similar to major depressive disorder. Lithium likely affects the intracellular processes, so we're talking probably about some sort of cellular expression. Appears to have a neuroprotective effect and possibly a neurotrophic effect. Untreated bipolar disorder is associated with decreased cerebral gray matter volume, so that's something to watch out for. So we really want to make sure that this drug is getting treated. Biggest problem with lithium is while it is incredibly effective in treating bipolar disorder, it is also rather toxic. You can get disruptions in memory and cognition. The side effect that is most related to noncompliance, so if we have this disruption, people are unlikely to stay on this drug. The risk for side effects, anything that will decrease kidney function will affect lithium levels. So reduced renal clearance can occur. You can get organic brain disorder, vomiting, diarrhea. Certainly no use of diuretics. If there is low sodium intake and high sodium excretion, all of these things can be problematic. Side effects can include tremor, cognitive impairment, nausea and weight gain, increased urination, hypothyroidism and goiter, and toxicity, because that balance of lithium levels is critical. So you have to be very careful with those levels. In terms of issues in lithium treatment, lithium is a teratogen, so it is not advised for use during pregnancy. Other drugs should be considered. Anyone on lithium should certainly probably be on birth control as well. Side effects often result in significant noncompliance, and it is most effective in combination with an antiepileptic or an antipsychotic. So lithium on its own is less effective than when used in combination with other drugs. There is a pretty significant study out on this called the Litmus test, the Lithium Treatment Moderate Dose Use Study, intended to answer the question of whether combining lithium with other mood stabilizers or second-generation antipsychotics resulted in any greater benefit by using optimized personal treatment designed to choose the best treatment choices. What they concluded in this study is that there is no difference between groups in measures of change in psychiatric symptoms, but the lithium add-on permitted less exposure to second-generation antipsychotics and accompanying side effects. So lithium seemed to improve symptoms with fewer side effects by combining those with other medications. So this optimized personalized treatment seems to be a really good way to go about picking the appropriate drug treatment for patients. So, while lithium is one of the drugs that is the sort of gold standard, bipolar disorder can be treated with mood stabilizers and other alternatives as well. So let's start by talking about mood stabilizers. We'll talk about a little bit about what these are, and then talk about carbamazepine or Tegretol, valproic acid, and then we'll talk a little bit about some other drugs like gabapentin and pregabalin and topiramate. So most of these mood stabilizers were originally developed as anticonvulsants. They are also important analgesics, but they are used in treating bipolar disorder. They're used to treat relapse to substance abuse, and oftentimes used as a detoxification agent for alcohol withdrawal to keep those convulsants and delirium tremens away. They are also used to treat behavioral dyscontrol and aggressive behaviors in PTSD, bipolar disorder, and in child and adolescent behavioral dyscontrol. So the point of using these drugs is for getting neuronal membrane stabilization is their mechanism of action. The drugs are all similar but a little bit different. Some have some antidepressant effects. Here we're focused on use in bipolar disorder, but we'll also extend our discussion into other what we call off-label uses. So there are often significant overlap with the newer atypical antipsychotics. Drugs of both groups are somewhat anti-bipolar. Drugs of both types treat aggression and violent behaviors in a variety of situations. And drugs of both groups have affective actions that may be beneficial, that it might improve affect. Unfortunately, all are also teratogens, so this is not an alternative to lithium for someone who is pregnant. Carbamazepine, or Tegretol, seems to be as effective as lithium in preventing manic recurrence. Some patients who do not respond to either will respond to both used in combination, so if lithium didn't work or carbamazepine doesn't work, the two of them together might. The mechanism of action is unknown, likely due to alterations in the sodium channel signaling. Some impairment of cognitive function is seen. There is certainly risk for a life-threatening dermatological condition, which is unfortunately greater in Asian populations. And there are significant drug interactions. Depakote, or valproic acid, is certainly well known as an anticonvulsant. There are new extended-release formulations that provide for daily dosing. It's approved for bipolar disorder, epilepsy, and migraine, so rather than having to take it multiple times a day, just once a day. Seems to have several mechanisms of action, including being a GABA agonist and suppression of neuronal firing. No surprise, if it's a GABA agonist, it would reduce neuronal firing. It's effective for treatment of acute mania, schizoaffective disorder, and rapid cycling bipolar disorder. Its side effects include upset of gastrointestinal systems, sedation, hand tremor, and hair loss. Black box warnings on this drug included its potential for hepatotoxicity and pancreatitis, so certainly something probably not to be used in things like alcohol withdrawal. Lamotrigine, or Lamictal, is approved and apparently highly effective in long-term maintenance of bipolar 1. Its mechanism of action blockade is a voltage-gated sodium channels. It's rapidly absorbed. Peak plasma concentration occurs in an hour to 5 hours and has a long 26-hour half-life. And importantly, seems to improve cognitive functioning in patients. So this may be, if one of the chief complaints is loss of cognitive functioning, this might be a good choice. Gabapentin and pregabalin are effective in treating neuropathic pain. In fact, these are what they are used primarily for. You've probably seen commercials for Lyrica as a treatment for diabetic neuropathy. It's not effective in treating bipolar disorder, but has an excellent pharmacokinetic profile with few drug interactions. These are related drugs. Lyrica is just simply a more potent version. Topamax is not supported as a treatment for bipolar. It has been used to prevent relapse to drinking and treating alcoholics, and appears to be a GABA agonist. But there is serious cognitive disruption, particularly aphasia, which is difficulty in word finding. So other uses for mood stabilizers include treatment for neuropathic pain, anxiety, borderline personality, and aggression and behavioral dyscontrol. So we'll start by talking about neuropathic pain. There's significant overlap in the underlying pathophysiology of epilepsy and neuropathic pain models. The lower doses appear to be effective in treating neuropathic pain, resulting in fewer cognitive side effects. For anxiety disorders, you can get significant improvement in generalized anxiety disorder, including improvements in sleep quality and overall functioning, and is a possible treatment for PTSD. Borderline personality disorder, which is notoriously difficult to treat, has responded to some of these drugs. Borderline personality disorder is characterized by emotional instability, impulsivity, including substance abuse, sexual promiscuity, and aggression. All drugs have been shown to be effective in treating bipolar and have some evidence as effective in treating borderline personality disorder. There is significant comorbidity between the two, so something to keep in mind. Aggression and behavioral dyscontrol, valproic acid and carbamazepine reduce intermittent explosive disorder and PTSD, and they both reduce impulsive aggression. There is ongoing research into how atypical antipsychotics can be used to treat bipolar disorder. All second-generation antipsychotics are appropriate for treating mania in bipolar disorder. Risperidone is effective in maintaining remission. Olanzapine is effective for bipolar depression. Movement disorders are more likely the side effect of antipsychotic in bipolar patients, so we want to watch out for that. A little interesting link between omega-3 fatty acids and bipolar disorder. There is a lower incidence of bipolar disorder in countries with a high fish intake. In one study, 30 patients followed for 4 months showed impressive results regardless of whether patients were taking or not taking other bipolar medications. Certainly we think omega-3s are associated with neural health. And for my money, evidence overall is mixed in terms of omega-3 fatty acids for bipolar disorder or for depression, but there are other health benefits for these particular formulations. So it really seems like a good thing to add, and certainly it's something to try. And so trying to find out the right dose and something that you can tolerate, because sometimes it can be difficult. But these omega-3 fatty acids have the potential to be a much better alternative, and certainly would be safe to be taken during pregnancy. So it's something to certainly consider. Certainly bipolar disorder patients need something beyond medication. Patients require social support via friends, family, or peers. Group psychotherapy appears to be helpful in managing the disease. It's critical these patients need assistance for drug compliance and recognition of side effects, so having some kind of social support is really important. So keep that in mind. Drugs are not the panacea here. They are simply a tool in the arsenal. So here is a sort of summary of the quality of evidence for the use of mood stabilizers in bipolar disorder. You can see whether or not these should be used for mania, mood stabilizer, or acute bipolar depression. Really, lithium and olanzapine and lamotrigine are the only ones that really have quality studies demonstrating their effect in acute bipolar depression. You can see most of these drugs are appropriate for acute mania or mixed, but again, talking about keeping mood stable over time, that's really what our ultimate goal is going to be. So there's potential for these drugs to get some of these drugs to get people through one episode, but then you have to think about the long-term treatment options. So one of the good studies in this area is the STEP bipolar disorder study. Antidepressants were added to mood stabilizers. Turns out they're no more effective than placebo for treating bipolar depression. Antidepressants, however, did not induce mania more frequently than placebo. Patients with an acute depressive episode who also had subsyndromal manic symptoms did not recover any faster with the addition of antidepressants. Lamotrigine showed benefit for treatment-resistant bipolar depression, and intensive psychosocial treatments showed the most positive results. So adding an antidepressant is probably not necessarily what you might need to do. So here are the recommendations for pharmacotherapy according to the American Psychiatric Association. For less severe manic episodes, first-line treatment is monotherapy with lithium, valproate, or a second-generation antipsychotic. For a mixed episode, the same. Lithium seems to be less effective. For severe episodes, you want to combine lithium and valproate or and an antipsychotic. For people who are rapid cycling, this is the most difficult. Lithium and anticonvulsants show low efficacies. Atypical antipsychotics appear promising, but this is probably the most difficult to treat. So those are the recommendations from the American Psychiatric Association. Again, bipolar disorder is something that really needs to be treated, and finding the best treatment for you or your loved one is sometimes going to be difficult, but getting treated and getting into treatment is incredibly important.